Hello everyone, I am Dr. Rashid Hassan, founder and CEO of DentoScope Institute of Research and Advanced Dentistry and Associate Professor and Head of Department of Dental Materials. Today, I am going to talk about the very important topic in the dental material subject, which is dental composites. So, without further ado, let's get started. Well, before we start with the different types of dental composite, there are few things, few terminologies which I would like to clear so that it becomes easy for you we move ahead. So, what exactly are the restorative materials? We are familiar with the fact that the restorative materials are used to restore carious tooth, and they are basically divided into two types. Either they are aesthetic restorative materials or non-aesthetic restorative materials. So these are the two main categories by which we divide the restorative materials. So what exactly they are? If we talk about the aesthetic restorative dental materials, they can either be direct or indirect. What's the difference between direct and indirect? The direct aesthetic restorative materials are those which are inserted or fabricated at the chair side. No third party is involved in direct aesthetic restorative materials. Like the patient comes to you, you do the diagnosis, and then you prepare the cavity, and then you restore the tooth with a restorative material which is present in your dental surgery. You do not involve a dental lab for these types of restorations. So they can be direct. These are called as direct aesthetic restorative materials. And second one are the indirect. Indirect type of the aesthetic restorative materials are those which require a third party, which is a dental lab. What exactly do you do? A patient comes to you, you do the diagnosis, and then you have to record the diagnosis, send it to the lab, and the lab fabricates the restoration, sends it to you, and then you insert it into the patient's mouth. These are indirect aesthetic restorative materials. Well, examples are quite clear in the direct aesthetic restorative materials. Well, dental composites, glass ionomer cement, these are the direct aesthetic restorative materials which are fabricated at the chair side, which are inserted into the patient's mouth at the chair side. They are available in the dental surgery. And the indirect aesthetic restorative materials are those which are fabricated by the dental lab, for example, the crown, all ceramic crowns, etc. Then non-aesthetic restorative materials, they can also be divided into two types, direct and indirect. So, as I told you, if the restoration can be fabricated or inserted into the patient's mouth directly without involving a dental lab, that is a direct non-aesthetic restorative material. For example, dental amalgam, which is present in your dental surgery, although it is not used these days because of certain reasons, but it's an example of the non-aesthetic restorative material which could be directly fabricated into the patient's mouth. Then the indirect one, well, they just like the indirect aesthetic restorative material, they also require a dental lab to fabricate them, like crown or they're like inlays, onlays, which are metallic. So they are non-aesthetic and they are prepared by the dental lab. That's why they are called as indirect non-aesthetic restorative material. And as it shows clearly that if aesthetics are the main concern, then the restoration should match exactly with the natural tooth structure. That's why it is called as an aesthetic restorative material. And if it is not matching with the adjacent tooth structure, then it is non-aesthetic. So let's move further. So we are going to discuss about dental composite, and dental composite is basically and direct aesthetic restorative material, along with we will mention as the lecture progresses. Um, well, well, here's the difference. The direct aesthetic restorative material, the first picture that you see, that is dental amalgam, which is a non-aesthetic restorative material, and then dental composite is a aesthetic restorative material, which matches exactly with the tooth structure. This is the anatomy of tooth. Different cusp grooves, everything is mentioned here, because in the next coming slide I'm going to discuss about different classes of cavities, so that when we talk about dental composites, it's easier for you to understand that where it can be applied, a specific type of dental composite, the application, where it can be applied for better results. So okay, so a very important thing that we talk about in dentistry is GV Black's classification for cavities. Well, GV Black was he gave this classification in around 1940 almost. On sorry 1915, he gave this classification, and according to this, he divided cavities into five main categories, right? Five different classes: class 1, 2, 3, 4, 5, and then class 6 was the modification of GV Black's classification. Well, he made a major contribution in dentistry. um, he talked about and he researched about different topics in dentistry, including the composition of dental amalgam, the best possible composition of dental amalgam that we talk about or we study in our dental materials, was given by the GV Blacks. And the about he also researched about the fluorosis, and then he invented the foot driven dental drill. Well, today we have very advanced types of dental drills, but GV Black was the inventor of the foot driven dental drill, and so on. But today we are going to talk about the GV Black's classification, and I will go through it one by one. Then let's have a look. Okay, class 1, class 2, class 3, class 4, class 5. These are the GV Black classification for cavities, and then class 6 was the modification. Well, class 1, well, it occurs in pits and fissure of all the teeth. Well, let's see them one by one. It is the class 1, present in the pits and fissures of all the teeth, not exactly for posterior, but all the teeth which have cavity, that will be referred to as class 1 cavity. This is a clinical picture of a class 1 cavity. Then class 2 cavity, proximal surface of the posterior teeth. Here it is, mesial or distal surface of any posterior teeth. If there is a carious lesion, then it is referred to as class 2 cavity. Well, just like this, this is the clinical picture of class 2 cavity. It occurs in the proximal of the posterior teeth. Then class 3, the proximal surface of anterior teeth that do not involve the incisal edge. Example, well, here you can see this incisor having mesial caries, but edge is it is not at all involved along with the incisal edge, referred to as class 3 cavity. It involves proximal surface of the anterior teeth but do not involve the incisal edge. And here is the clinical picture of this. Only the caries lesion was present on one side, the distal side, and incisal edge is intact. Then coming to the class 4 is at the proximal surface of the anterior teeth that do involve the incisal edge. Well, it's you can say the advancement of class 3, where only one was involved but incisal edge was intact. But here the proximal as well as the incisal edge both are involved, so it is class 4. This is the clinical picture of class 4 cavity. Then cavity, the gingival third of facial and lingual surfaces of all the teeth, except pit and fissure. Because if the pit and fissure, it will be class 1. So except pit and fissure, there is a carious lesion at the gingival third of the facial and lingual surface of any teeth, just like this. Here you can see class 5 cavity according to GV Black. You can see the lesion which is blackish, mentioned in the blackish color here, that it is present on the gingival third or anterior tooth, then it will be at the facial third or the lingual surface. But it do not involve the pit and fissure, because as I told you, pits and fisheries, if they are involved, that will be, so it is except pit and fissure lesions. And uh, and here is the clinical picture of class 5 cavity according to GV Black. Then comes the modification of GV Black's classification, which is involving just the cusp tips. Only the cusp tips are involved in class 6 uh, classification of caries. Uh, Here you can see the carious lesion is present only on the cuspal tips. And here is the clinical picture of this. So I have explained all the five types, five classes of the classification, and the sixth one, which is the modification present on the cusp tip, only because now we are going to move ahead and start with composites. And when the application of dental composite it comes, these are the classes which I am talking about. So okay, yeah, this is another slide which mentions the natural composites present in the human body. Well, this the first line. This is the MCQ. The natural examples of natural composites are enamel, dentin, and bone. Well, this is animal choice question. Now, here we see the two types, enamel and dentin. I have just mentioned these two types for your better understanding. Here you can see the composition of enamel and dentin. The composition involves the organic component and inorganic component. Well, what isn't? So just pay attention that the natural composite, which is enamel dentin, and same is the case with the bone. If you look at the composition of bone, it will also have an component and an inorganic component. So it is the combination of these two compounds. Same is the case with enamel, same is with dentin, and if you look at the composition of bone, that will be the same. So just keep this thing in mind, that the natural composites have inorganic and organic part. So there are four types of materials which can be classified as direct aesthetic restorative materials: dental composites, glass ionomer cement, hybrid ionomers, which is a modification of GIC, glass ionomer cement, and then compomers, which is basically a combination of dental composites and the glass ionomer cement. So these are the four direct aesthetic restorative materials which can be used to fabricate the aesthetic restoration into the patient's mouth directly. And today we are going to talk about the dental composites. I have also scheduled a lecture on glass ionomer cements. You can check that on the channel updates. Dental composites. Well, how do we define a dental composite? A composite is basically a material which is formed from two distinct phases. If you keep in mind, I told you about this when we were discussing about the natural composite. So two distinct phases. One is the organic phase and another one is the inorganic phase. So combination of these two phases is called as the dental composite. And why we need a dental composite? Because we want to get a material which have either the intermediate properties or superior properties to the individual component. We mix two types of materials. They both of them have good properties, and we want to mix them to get a material as the properties of both of them much more superior, right? So that's why a composite is fabricated, that it should either have the superior properties to the individual component, or basically maybe in intermediate properties. So that's the main purpose of having two distinct phases. Well, now talking about the composition of dental composites, this is a very important short essay question which is asked in the exam. So keep this thing in mind that there are four major components of dental composites. I'll talk about them one by one. The four components are basically organic polymer matrix, inorganic filler particles, coupling agent, and initiator activator system. So these are the four. A composite, a dental composite, is made up of four components: organic component, inorganic component, coupling agent, and then initiator activator system. So here, if you also see, just like the natural composite, here you also can appreciate that there is an organic component, organic polymer matrix, and inorganic filler particles. So it is also like the natural composite, right? Because it is a mixture of an organic part and an inorganic part. So, organic polymer, basically plastic resin material that forms a continuous phase. So, as I told you that the composite is a mixture of two. One of them is a continuous phase, and other one is the dispersed phase. The continuous phase is formed by the organic polymer matrix, and then the second component, the inorganic filler particles. Well, they are the dispersed phase. They are dispersed polymer matrix. They are dispersed all around the organic component to give extra strength. We will talk about the inorganic component, the benefits of the inorganic components. They are very much crucial in dental composites, and I'll discuss them later as we progress. So, so it should be clear that it has organic component and an inorganic component. One is the continuous phase, and the other one is the dispersed. Then, well, they both phases are not joined together. They they are only joined together by a third component, which is called as the coupling agent, which is the binding agent which forms the adhesion between the organic component and inorganic component. These two components are joined together by a coupling agent. Also, you can call it a binding agent, because if the organic and inorganic components, they are not joined together, then there are not going to be any or greater properties that you can get from dental composite. They, for the best properties of composite, the organic component and inorganic component must be joined together, and uh, that what you can say, that served by the coupling agent. They perform the function of joining these two components, organic and inorganic. Then lastly, the initiator activator system. Well, this is mechanically activated, or the light activated, or dual activation is also seen. So now I will each one of these components in a bit detail, so you could understand it. So the first component is organic polymer matrix. Organic polymer matrix, which is a continuous phase. Well, in most commercial composites, the organic matrix is dimethyl methacrylate. Dimethyl methacrylate oligomer is the polymer matrix which is used. And what exactly an oligomer is? Oligomer is basically a type of polymer, but the viscosity of this oligomer is so a thick viscosity material. Well, it cannot serve our purpose. It is not at all helpful for the in the cleaning or restoring the tooth. So what exactly do we do? uh, I will talk about it in a couple of minutes. So, two most commonly oligomers which are used in dental composite, either they can be bis GMA, which is commonly called as bis gamma, or gamma urethane dimethacrylate. So these two oligomers are most commonly used. They have thick viscosity, and to make their viscosity into a workable one, we need to add a low molecular compound, which is triethylene glycol dimethacrylate, TEC-DMA. TEC-DMA is added to any one of these oligomers to make the viscosity thin, so that it could be easily worked and it could be easily used to restore the tooth. So basically the oligomer is bis GMA or UDMA, and the low molecular compound, which is TEC DMA, is added so that we could get a workable mixture. Okay, then the second one is the inorganic filler particles. This is one of the most important component of dental composite. The inorganic filler particle, glass or quartz silica, zirconia, nanoclusters. Well, they can be used as inorganic filler particles, but most commonly glass and quartz and colloidal silica, they are used. Well, filler particles basically are used to improve the material properties. All the properties of dental composites are basically depend upon the filler particles and amount of filler particles in the dental composite. Okay, that which filler particle is used and how much of the filler particle is used. It is also very important because the inorganic filler particles, the dental composite is basically even classified on the basis of the filler particles. So filler particles hold very much importance in the composition of dental composite. And for better properties, I told you that there should be a strong bond between the organic and inorganic part. So, okay, what are the benefits of the inorganic filler particles? The primary purpose of the filler particles is to provide the strength to the dental composite, because the strength is not seen in the organic organic polymer matrix. Organic polymer matrix has no function in strength. The strength is basically provided by the inorganic filler particles. And besides strength, there are different things that properties, I should say, that the inorganic filler particles, they increase or decrease. So let's go talk about them. So in dental composites, the inorganic filler particles, they increase the hardness, strength, viscosity, workability, and radio opaque. Different radio opacifiers are also added so that we could appreciate it in the dental radiograph, and it reduces the wear, the polymerization shrinkage, thermal expansion, and water absorption, softening, and staining. So these are the things which inorganic filler particles decrease, and here the hardness, strength, viscosity, etc., well, workability. These are the properties which dental uh, in the dental composites which are due to inorganic filler particles. If you look at this table holistically, you will see that whatever the inorganic particles, whatever property they are increasing or decreasing, are basically beneficial for our restoration. If it is increasing hardness, strength, workability, viscosity, then radiopacity, it is beneficial for our restoration. And if it is reducing the wear, polymerization, shrinkage, thermal expansion and contraction, softening, etc., then it is also beneficial for our composite restoration. So in either way, either you increase the properties or decrease whatever the inorganic filler particles they are contributing, they are basically contributing in a better way. They are increasing they are helping the dental composite to get more and more strength. Well, composites are classified on the basis of the filler particles, the average size. As I told you, that filler particles hold very much importance in the dental composition. So, because of these filler particles, we basically classify dental composites as well. So, filler size, the amount of fillers, which is called as the size distribution, the reflection, whatever the material they are using, how much they reflect, the light. I will also talk about it in a bit detail in the coming slides. Then radio opacity, hardness, filler density, then the properties and the clinical application of the resultant composite. I told you that inorganic filler particles, they contribute a lot to the prognosis and success of a dental composite restoration. So inorganic filler particles, they basically from 30 to 70 by volume or 50 to 85% by weight, they are present in the composite. um, and maximum amount of fillers that you can add in a dental composite, theoretically according to the different books, is 74% by volume. More than 74%, well, that's not going to serve your purpose, because then the polymer matrix and the other components, the percentage is going to be lowered. So that's why theoretical, what you can say, theoretical amount of inorganic filler particles that you can add, well, that should be about 74%. So then the third component is the coupling agent. Well, the coupling agent, chemical properties, all the chemical properties and the, what you can say, the good properties of dental composite, well, they are dependent upon a strong bond between the organic and inorganic component. The first two component, this is the third one, coupling agent. So first two, the best properties of dental composite is basically dependent upon a bond between first and the second component, and that is provided by the coupling agent, which is called as the binding agent. uh, Titanates and zirconates, well, they are mostly used as the coupling agent and most commonly used. This is an important MCQ. Silane coupling agent is the most commonly used coupling agent in the dental composite. Organosilane or silane coupling agent. Well, this is the most commonly used coupling agent in the dental composites. Then the fourth component, the initiator activator system. I told you in the introduction that it can either be light activated or chemically activated. In case of light activated, there is a special component which is added, which is known as camphorquinone, because it has a tendency to get activated by blue light. It gets activated by the blue curing light at 470 nanometers. The normal, the curing light that we use in the dental surgery, it has the wavelength of 470 nanometers. And the second one is the chemically activated composites. Well, they are available in two paste formulation. The paste paste formulation, when you mix both these pastes, the polymerization reaction starts. So this is a different light activation and the chemical activation. In light activation, you get some extra time, right? You can prepare the cavity, isolate the tooth, and then you take out the light cure dental composite, and then insert it into the cavity, do all the carving procedure, and then you activate it by blue light. And after your activation with blue light, then the polymerization reaction starts. But here in this case, in the chemically cured dental composite, the polymerization starts as soon as the two pastes are mixed. You need to be very much expert while using a chemically cured dental composite. Then different types of packaging in the dental composite. Um, well, light cured dental composite, where they are supplied in different shades. Of the light cured dental composite, you will see different shades of the dental composite, and you can match it with the existing tooth of the patient, and then you can use the specific shade so that you give an aesthetic look to the restoration. Well, they are available in the form oil syringes and capsules. Most commonly, they are available in the form of these syringes, which are in darker in color. Um, well, these syringes, the dental composite, they are always made up of opaque plastic, right? They are made always you will see the dental composite, it will have a plastic covering, and that will be opaque, so that to avoid any ultraviolet light to reach up the dental composite. Because although it will get activated by blue light, but some activation process also starts once once even the ultraviolet light is there. So once the ultraviolet light reaches the dental composite, well, that's curing it. Okay. Now moving ahead, what are the different steps to manipulate the dental composite? Well, in case of an amalgam restoration, there are different steps, but in case of dental composite, it is very straightforward preparation. You diagnose the what type of cavity it is, you remove all the carious lesion. Then, if in case the cavity is very deep, you have to provide a pulpal protection either by calcium hydroxide or any other pulp agent. Then there is etching and bonding. Etching and bonding are the main by which the dental composite adheres with the tooth structure. If you're just going to place dental composite into the tooth cavity, well, it's not going to adhere with the tooth. Dental composite is adhered with the tooth structure by bonding, which is called as micromechanical bonding, and micromechanical bonding is provided by the etching. So you have to etch the tooth with phosphoric acid, and then clean it up. It gives a chalky white appearance, and then you apply the bonding agent, and then the tags are formed, and then you insert the dental composite. So etching is the main method by which dental composite binds with the tooth structure. Then you dispense the dental composite from the syringe as directed, and place it into the cavity that you have prepared. And then the polymerization reaction starts as you put the blue light after doing all the carving procedures. Then you do the finishing procedure so that the final cavity, the final restoration is smooth to avoid the lodgement of any food debris. So, on the basis of curing, the dental composites, they can be either chemically activated, light activated, or dual cure. They can either be chemically cured or dual cure. So, I'll talk about them in the coming slide. So, the first one, which is the chemical activation. Well, there are different names by which we refer a chemical activation as cold curing, auto curing, or self curing composites. So these are the different names. So as I told you that I always take lectures from different books. So whatever the information is there, I try to gather it in one lecture, so that whatever terminology is asked from you, you are easy. You are easy to answer about it. So, self cure, cold cure, auto cure. These are the other names of the chemically cured dental composite. The chemical activation, well, that is initiated by mixing the two paste. I told you that the chemically cured dental composite, they have two paste, base paste and the catalyst paste. And as soon as you mix, the polymerization reaction starts. So the chemical activation is initiated by mixing the two paste, and during mixing, it is almost impossible to avoid the incorporation of the air bubbles, right? So because air is present there in the atmosphere, and when you are mixing a chemically activated dental composite, it is really very impossible to avoid any incorporation of an air bubble. So you need to be very expert, and very high expertise are required when mixing these two pastes, so that to have minimum of chances of any air bubble, because that's not only going to inhibit the polymerization reaction, but also it's going to create voids or spaces once this restoration process is done. Well, curing is inhibited by the oxygen. I told you that once you expose the base paste and catalyst paste and start mixing it, the oxygen present in the air, well, that also acts as an inhibitor of the polymerization reaction. And most importantly, the operator who is mixing the two paste, he has no control over the working time once the two pastes are mixed, because once the two pastes are mixed together, the polymerization has already started. So you need to be the assistant should be very very sharp. The operator, the dentist, he should also be very very expert to take that material and insert it into the cavity and do all the caving procedure, because the polymerization reaction has already started once the two pastes were mixed together. So operator has no control over the polymerization reaction or the working time once the two pastes are mixed together. Now let's talk about the light activation. The light activated dental composite, they do not require mixing. They are available in the syringe form, as I told you. I showed you here. Um, Here, they are available in these syringe forms. And what exactly do? You just remove the cap and take out the required material, and then use it into the cavity that you have prepared. So you don't have to you have no need to mix the anything. Just you take out the material and just insert it. It is composed of the photosensitive initiator, and light source is required for the activation. As I told you, camphor quinone is used for as a photo initiator, right? And it blue light, it starts the curing process. The operator has, this is the thing I want to point. Well, that is the main difference between a camphor cured and a light cured dental composite. That operator, he can easily control the polymerization reaction. He can easily take out the dental composite, insert it into the cavity, uh, make all the margins, the anatomy of the tooth, do all the carving procedure, and recreate the anatomy, and then he can introduce the blue light. So he is in full control of the polymerization reaction. Well, exposure time of 40 seconds or less is required to light cure 2 millimeter thick layer. Well, why 2 millimeter? These dental composites is always inserted in increments. If let's suppose you have a 3 or 4 mm deep cavity, you are not going to fill the whole cavity with one time with dental composite. Why? Because the curing depth is only 2 millimeter for dental composite. More than 2 millimeter, it's not going to cure with blue light, right? Why? Because of the presence of filler particles. The filler particles, as I told you, had glass into it. So these glass particles present inside the dental composites of 2 millimeter thickness, they basically reflect light. They reflect light. I told you about the index of reflection, what significance it has. I said that I will talk about it in the next lecture. So this is the significance. The glass particles which are present as a filler particles in the dental composite, they basically reflect light, so they don't allow the light to move even to a greater depth. So that's why we only use 2 millimeter of thickness of dental composite, cure it for 30 to 40 seconds, and then after that we just introduce the second increment and then cure it with light. So that's the procedure of filling tooth with dental composite. You need to insert it in increments because of the presence of filler particles which reflect the light, so it reduces the depth. So that's why we use less quantity. So limited depth of light penetration. I told you because of the presence of the glass particles, the depth of curing is very very limited, because the glass particles, which are the inorganic filler particles, they reflect light from the air. so it is unable to reach the whole depth of the dental composite. So that's why we use smaller increments. The cost of the light curing unit, well, that is another drawback. Well, not now, because now this curing light, well, they are available in very cheap prices as well. So it is not a big drawback these days. Then, besides these four components, I've talked to you about. Okay, there are two different types of the curing procedures. That the third procedure is dual cure. Dual cure has both light activated and chemically activated dental composite. It's a combination of both these. So it is in paste formulation. You mix the toothpaste and then you insert it into the cavity that you have made, and then you introduce the blue light, so it gets activated by mixing as well as by the blue light. So by that's why it is called as the dual cure dental composite. So, okay, coming to the minor additions, well, inhibitors, they are used to inhibit the polymerization reaction so that we can easily control the working time. And then there are color modifiers which are added so that we can get an aesthetic restorative appearance uh, to match exactly with the tooth structure, either adjacent or the same tooth structure. So that's why the color modifiers are added. Well, let's talk about the light activating activation. They have different advantages and disadvantages. There is that you do not require any mixing and more color stability than chemically cured. Yeah, the restorative cured by light, their color stability is much more higher. The prognosis of color stability is much more higher compared to the chemically cured dental composite. And obviously, the operator has control over the polymerization reaction. He can easily, as I told you, clear the cavity and do all the isolation, and then insert dental composite, and then he can use the blue light, and the polymerization reaction is going to start. Well, the disadvantage is limited curing depth. That's why the light cure they must be used in increments. Uh, then poor accessibility in the posterior interproximal areas. Obviously, when let's suppose it's a dentistry cavity and a caries is present at the distal side of the upper second molar, let's suppose. So the accessibility is going to be a big problem. That how you have the cavity, but how you are going to insert the dental composite in that area, that becomes very difficult because it is not at all in a fluid state. It has high consistency. So variable exposure time for different shades. Well, that is also dependent upon the manufacturers. The manufacturer, they gives all the guidelines about different time of curing for different shades. So you need to read through the instructions of the manufacturer. Okay, sensitivity to room illumination. Well, not too much. Room illumination is not as intense as the blue light that we use to cure. So, but still, it's a disadvantage. It can initiate the polymerization reaction. Cost of the light curing unit. Well, it is costly, but now because most of the brands they have come into the market, so you can easily get one in a good price. So, yeah, I'm going to talk a little bit about the visible curing light units. What exactly light units are used in the dental composite? The first one is quartz tungsten halogen, plasma arc. Then there are lasers, light emitting diodes. So let's talk about them one by one. Okay, the first one is quartz tungsten halogen. This was the first curing light which was introduced for dental composite. You can see in the picture it has wire to be attached to the electricity, and then you can see this orange color filter. And here at the back side of this curing light, you see different holes. Well, underneath these holes, there is a fan which keeps on moving to keep the curing light cool, because after some time this the temperature of this curing light, it gets very warm. So emits light both in ultraviolet and white light regions. So it can easily work in this uh, dental clinic environment. The disadvantage, well, it becomes warm. As I told you, it becomes warm. uh, let's suppose if you want to do 2 or 3 fillings and you need to cure 2 millimeter or increments for all those cavities, it will become warm after some time. So intensity of the quartz bulb, it also decreases with time. So the quartz resistant bulb which was used in this type of curing light, well, it was not very you can say it was not very stable for a longer duration of time. The more you use it, it will the intensity will keep on decreasing, and after some time you need to change the bulb. So it was very much you can say it was first, it was very much expensive in the start, and the secondly, it required a lot of maintenance. And if it gets more and more warm, then even the fan could also be damaged. So there were problems with the this first type of curing unit. Then plasma arc curing unit, it uses the xenon gas. It works on the gas, and intense white light is filtered. So in this type of curing unit, only white light is filtered out. So it was also very much expensive, the plasma arc unit, and it is not used in dental surgeries for dental composite. Well, this is the most commonly used curing light in dental composite, which is light emitting diode, LED. LED curing light, the most popular and most commonly used. Here you can easily see, well, this was basically the modification. Here you can see the filter, and then you can change the time and do all the settings, the start and the stop button. Everything is panel is mentioned on the panel, and this small screen is there to give you the idea which mode you have selected. And the second thing is advantage is that it is cordless. You can easily charge it like you charge your mobile. You just put it on the stand for charging, and then you can easily move it. You can easily change the light even if there is some electricity issue, but still you can do a composite filling, because this light does not require the electricities. It is already cordless, so you can use it. So it emits light in the blue region. It is the blue light that exactly which is required to activate the Halogen, which is the photo initiator. Well, the wavelength is between 440 to 480 nanometer, and due to that camphor quinone, it gets activated at 470 nanometers. So it is exactly it covers. It can be cordless. That's exactly what is used nowadays. We prefer the cordless light emitting diode unit. And what do you see? You cannot see any fan or any holes in it from to emit all the heat generated. So it warm, it stays cool, and it does not produce any heat. So that's why it is most commonly used in dentistry these days, and it's not at all very expensive. Then argon laser lamps, well, they are very much expensive because not everyone can afford these laser lamps, uh, because it also increases the cost of the restoration. It emits high intensity of light, well, much more higher than the what is required for the camphor quinone. It emits light of a single wavelength of 490 nanometers. So 490 nanometer light is quite high, because our camphor quinone, it gets activated at 470. So a few disadvantages, like the high cost of this laser lamp, and then the intensity of light. Uh, which is intensity of wavelength of light which is generated is also a bit higher than what is required for camphorquinone. So this was some brief uh, review about the two types of the curing units. Well, now let's talk about the classification of dental composites. Well, composites are classified, as I told you, the fillers, the inorganic filaments, they play a very important role, a very major role in the composition of dental composite, and also they play a role in the classification. We classify dental composites on the basis of the inorganic filler particles. So, a composite with fillers from two or more different types, these are called as hybrid composite. We are familiar with the hybrid cars we see nowadays, which operate on battery as well as on the petrol. So there are two ways by which we can drive those cars. Same is the case here. If the composite has two or more different types of the inorganic filler particles, we call it as the hybrid component because it has two different types of the uh, com- uh, different types of the filler particles. Well, then there are the packable composites. Well, these are the two special categories of the hybrid composites. The both these types, the flowable and packable, well, there's a difference between both of them, and I'll mention it as we progress. These are the special categories. Okay, well, this is the table. You can easily appreciate. I have summarized all the composites here so that you can understand them in an easy way. Well, first of all, the large particle size. Well, it has the particle size of about 1 to 50 micrometer glass. The glass is used to drive the um, inorganic filler particles in the traditional one, and it can be used in the high stress areas. So high stress areas, your molar region, where the maximum masticatory forces they are produced. So we can use this to reduce high stress areas. Then there are hybrid the composites. There will be large particle, mid filler, mini filler, which are also called as the hybrid. Then there are packable and flowable composites, which are the two hybrid composites. Well, talking about the hybrid large particle, here you can see two different types of particles: the glass particle and the silica particle. So, as I told you, then two or more types of particles are used in a dental composite composition. We call it as a hybrid particle. So, only changing the size changes the name of your dental composite. Because they have larger size, they are called as large particle. Then if the size is medium, they call it mid filler. Then if the size is even smaller, it is called a small particle filled. But the particle that you see, the two types of inorganic filler particles, all these three are colloidal silica and the glass particles. Well, they are used in different classes: class 1, 2, 3, and 4, and high stress areas. Then the hybrid mid filler, well, they are usually in class 4. I mentioned all these classes in the start. So if you have joined later, you can, after the lecture, you can just go into the where you can find all these different types of GV Plex classification for dental caries. Well, then the small particles. Well, we'll talk about these in detail later, but just mentioning a bit, you can say summary of everything. Well, moderate stress areas. Moderate stress areas, which are class 3 and class 4. Well, these are areas which have high stress power on them. Right? High stress is not just confined to these particles. So that's why we can use it in those areas. Then there are the flowable. Well, I will discuss both of these in the coming slides. Just okay, homogeneous or heterogeneous. Homogeneous having same particle, and the heterogeneous having two types of particles: the silica particle and pre-polymerized particles containing silica. So it has two different types of the sizes, what you can two different size of the particles. One is silica and the other one is silica but is already polymerized, pre-polymerized. So this is the heterogeneous dental. And they both are used in the low stress area. You cannot use the homogeneous and heterogeneous dental composite in high stress areas because they will easily fracture. Okay, now let's talk about them one by one. The first one is the traditional composite, which is also called as conventional or the macrofilled composites. Well, these were the first of the dental composites which were introduced in the market, and as the name suggests, that's why they were called as the traditional composites. And as the name says, that they are macrofilled. It means that the particles that were used, the inorganic filler particles that were used in these dental composites, well, they had larger size, the larger particle size. Well, and now we have much better dental composites of this traditional composites. The average size of the particle here was 8 to 12 micrometer, and they were 50 micrometer large particles present in the composition of dental composites. Now we don't use it, but in the start, this was the only composite that we had when the composites were coming into the market. Then the first type of filler was 70 to 80% by weight or 60 to 70% by volume. So rest 40 to 30 to 40% was your polymer, your coupling agent, and your initiator activator system. One disadvantage of the traditional composite was roughened surface. Well, that was a big disadvantage, that due to the large particle size, the surface was the major drawback, because of this surface you could not easily polish or finish these traditional composites. So that's why it had roughened surface, and roughened surface are basically very big disadvantage. It lodge poor particles onto its surface, and with the passage of time, your restoration starts to discolor. The restoration, as the second point says, restoration tends to discolor over time. That's only because of the roughened surface, because the food, the colored food that we take, the food, everything that we take is almost colored. So that adds up onto the surface of the traditional component, and that's why it discolors with time. Occlusal wear was a very big problem. If a patient had this traditional composite filling and he keeps on chewing, after some time the occlusal surface of the dental composite filling, it will wear off. It will be just a straight occlusal table. So occlusal wear was the poor resistance to occlusal wear was a very big disadvantage. But having a big table, it had just one advantage, that it was resistant to fracture. That's why if you remember, I mentioned in the that table that it was used in the high stress areas because it would withstand the high forces. It was resistant to fracture because of the large particles. Then the second important type of composite is the small particle filled composite, also called as SPF composites. Well, they were the composites which were introduced in the market and only to improve the surface smoothness and to improve the physical and mechanical properties. But there were some disadvantages. If you see, these were the disadvantages of the traditional composite. That it has roughened surface and it has poor resistance to the occlusal wear. So these disadvantages were overcome by the next generation or next type of dental composite which was introduced in the market, because it was used to improve the surface smoothness and also the physical and mechanical properties. Well, the average particle size, if you see here, the average particle size of the small particle filled dental composite was zero point 0.5 to 3 micrometer. Okay, here if you remember, it was 8 to 12 micrometer. So now it has reduced quite a lot, zero point 0.5 to 3 micrometer. It is quite a lot reduction. So highly filler loading as compared to the conventional composite, because in conventional composite the particle size was quite large. Here the particle size is very small. So it's just like if you have box and you fill it with the uh, normal cricket balls, you will have less amount of cricket balls in that box. And if you fill the same box with these table tennis balls, you will have more of them just because of the size. The smaller the size, more the loading. Larger the size, less the loading. So we will have more fillers into our dental composite. That's why all the properties, all the benefits that I told you in the start, which were because of the filler particle, more the filler the properties are going to improve more, right? So because of the size of was small, so there was more filler loading in the dental composite, 80 to 90%. Okay, 80 to 90% is quite high, and it is designed for the posterior restoration so that it can withstand the occlusal forces in the posterior molar regions. So, what are the clinical considerations of a small particle filled dental composite? It had greater strength and improved physical properties as compared to your traditional ones. Indicated for use in high stress areas and abrasion prone sites. For example, class 4. Class 4 was the prone site because if you remember the class 4, it had the proximal caries also involving the incisal edge. So incisal edge is also going to be constructed or restored by the small particle filled, and due to large filler loading, they can withstand the abrasion there. So smooth surface of the interior in the small particle, but they are not as smooth as the microfilled composite. Microfill composite are going to be very fixed. So okay, the problems of the surface roughness and low translucency associated with traditional and the small particle filled composite, they were overcome by the microfilled composites. Well, we are familiar that the traditional composites had a lot of problems, uh, and so does the small particle field because the translucency was very low. So to overcome these problems, the microfilled composites were used. And here, if we see the individual particle size is so much small, 0.04 micrometer, right? Here it was 0.5 to 3, and previously it was about 8 to 12 micrometer, and here it is 200 to 300 times smaller than the average particle size of your traditional composite, which was introduced right in the start. So now we have reached to this level that we have reduced the size of the filler particles to a much smaller one. 40 to 80% of the composite consists of the resin. So in this composition, there is more resin and less filler content. So we have increased the amount of organic filler particles so that we could have a much better translucency and surface smoothness. Because the more organic polymer matrix, the more is going to be the smoothness. Okay, what are the clinical inclinations of the microfield composite? Well, there were few things which were increased, but because of this, there were few things which were compromised as well. What are the physical properties? Well, SPF, small particle field, has the best uh, physical properties among all the composites. Well, potentially greater in high stress areas. That's why it is not used in the high stress areas, in the molar areas, because it has less fills. Here we see 40 to 80% consist of the resin. Resin means your organic component. Strength and hardness, these properties, they come from the inorganic component. So inorganic component is quite low in the microfill dental composite. They can easily chip off due to debonding. So in order to finish it, diamond burrs rather than the tungsten carbide burrs are used to finish the dental composite. So we do not use tungsten carbide burrs because if we're just going to touch the tungsten carbide burr with a dental composite restoration for the finishing process, it's going to chip off. the composite is going to chip off and the whole restoration is going to be a failure. Well, it produces best smooth surface, so it is only indicated for the low stress areas. And which are the low stress areas? Yeah, class 5 cavities, which are present on the buccal 1/3 area. Well, they are your low stress area. No stress is being applied on the in the class 5 cavities. So we can only use microfield in the low stress area. Then coming to the hybrid composite, well, they were developed in order to obtain the better smooth surface while maintaining the durable properties of the small particle field. So we wanted to keep the good properties of SPF, because by now we have studied the traditional small particle field and microfield, and among all these three, small particle field, they had the best properties. So to improve its property, we created the hybrid composite, which are most commonly used these days. The hybrid composite, they contain two types of filler particles. I told you that because of this property, they are called as the hybrid composite, because they contain two types of filler particles. One is glass and the other one is the colloidal silica. The filler content is 75 to 80%. That's exactly what we require. More filler, more strength, more hardness. So they reach particle size of zero point 0.4 to 1 micrometer, whereas the colloidal silica, well, they are present in the 0.04 micrometer size. So these are the different two different sizes of the materials, which are the filler particles which are used in the hybrid composites. Coming to the clinical consideration, they have good surface smoothness and good strength, reasonably good strength. So it is better than those microfilled and the glass. Okay, widely used for the anterior restoration, including the class 4 sites. So now we can easily use it in the class 4 restoration, which also includes the proximal and the incisal edge. The mechanical properties are inferior to the small particle field, but it has a good surface hardness, so it gives a good lustrous translucency when it is inserted. So it gives very much natural appearance. So widely used for the stress bearing, well, the stress bearing posterior restoration. Well, they the hybrid composites, as I told you, they are most commonly used these days, because almost all the composites that we use, they are hybrid, only because they could be used in the high stress areas in the posterior lines. Now let's talk about the two different types of the hybrid composites. I told you that flowable and packable are the two special categories of the hybrid composites. Well, this is the modification of the SPF and the hybrid composite. Well, flowable, as the name suggests, that these composite, the viscosity of these composites is quite low. They easily flow into those unreachable areas where we could not reach with the natural or normal composite that we use, the traditional ones. So that's why. And how we going to reduce the viscosity? By adding more polymer matrix and reducing the filler content. The lesser the filler content, the more the viscosity. Here it is mentioned, reduce the filler content reduces the viscosity of the resultant composite. So reduce filler content, but the disadvantage. So all the benefits of the dental composite, which were due to the inorganic filler particles, if the filler content is going to be reduced, the benefits are going to be reduced. So it's going to be have more wear. Helpful for the practitioners in the adaptation of the margins, just like in class 2 cavities. Let's suppose that there is I told you there is a class 2 cavity which is present in the lower second molar, let's suppose. So, and on the distal side, so these flowable composites, they can easily flow to that area, and they can just fill that areas easily, because their viscosity is low, they can easily flow. So it can also be used to prevent the caries when used as a fissure sealant. They are all, yeah, for pit and fissure sealant they use the flowable composite, because there are some patients in which the pit and fissure caries is a major problem. So we can do the pit and fissure sealants by the flowable composite. Then coming to the properties and clinical uses, well, they are similar to the compomers. The compomers, well, they are not used in the high stress areas, and that's why. And physically, they are very smooth and lustrous. So that's why the flowable composites, they also have the same properties. Now coming to the packable composites, well, the as the name suggests, these are directly opposite to the flowable ones. They have thick viscosity, but here, okay, I will tell you something important in a few moments. Because of the high plastic and the plastic lichen system, they cannot be packed vertically into the cavity to ensure the intimate contact with the cavity wall, and that's why the normal composites are packed vertically. So that's why the packable composites were used. Well, the packable composites, uh, and well, they are also called as the flowable composites. They form two special categories of the hybrid composites. Hybrid composites, well, they can either be packable, flowable, and you can easily condense them. They are also called as the condensable. The only component I told you that in all the dental composites, the inorganic filler particles were in the form of particles. They were either colloidal silica or they were the glass particles, nanoclusters, whatever. But in case of the packable composite, well, the fillers are in the form of fibers. This is the Viva question, mostly asked from the students in the Viva, that which is the only composite which do not have the filler particles in the particle form, right? The students, they get confused because if they are good in dental composite, they have studied it quite well. They know that the it is the component of dental composite restoration, the inorganic filler particles. So they are unable to answer it. This is the packable composite is the only composite which is used uh, in the dentistry, having the filler particles in the form of the fibers of 100 micrometer length. So just note it down. That's a very important Viva question. Now coming to the selection criteria, how do you select a patient for a dental composite restoration? Well, every patient is not suitable for a posterior composite restoration. The dental composites, well, they are mainly the aesthetic restorative materials. So mainly they could be used in the anterior region. In the posterior region, the best choice is still, according to both, the amalgam is still the best restorative material for the posterior teeth. But now we don't use it as because of the mercury toxicity. We don't use it. But in practice, we use in student time we used to do dental amalgam restorations, and it produced best results. Then the primary indication for using a dental composite is the place of amalgam in the posterior region is only aesthetics. Only aesthetics is the only reason in which the dental composites could be used in the posterior teeth. Other than that, well, dental amalgam is the material of choice. Now, coming to the third point, which is conservation of tooth structure. Well, when you will study about the cavity designs, you will come to know that from making dental filling, if you want to do a dental amalgam filling, well, you have to make certain designs. As you could see in the start, I mentioned GB Black's classification. Uh, you could easily see different designs of cavity. Well, a very important step in the fabrication of the dental amalgam restoration cavity is extension for prevention. Sometimes you have to cut down the extra normal tooth structure also to prevent the chances of secondary caries. That's the idea of extension for prevention. You extend the cavity wall to the normal tooth structure. You just cut down the normal tooth structure as well. So that's why they are used. So in case of the what I want to say, in case of dental composite, the tooth structure is conserved. You only drill, you only remove the carious part, and then drill the normal tooth structure. So the tooth structure is conserved. So that's also a plus point for the dental composite restoration. Next is the thermal conduction. Because the tooth structure is intact, we do not remove the extra one, so the thermal conduction is minimized. Inferior physical properties than the dental amalgam and should not be used in the cuspal areas. Well, it is contraindicated to be used for the cuspal areas because occlusal wear can occur, but due to the inferior properties, because cuspal areas are the most areas. These are the areas where the maximum masticatory forces are applied. So, and with that, the occlusal wear is going to happen. So that's why they are contraindicated. Also contraindicated in the patients with the parafunctional habits. Well, in case of the patients which have these parafunctional habits like nail biting or any other parafunctional habit, well, dental composite is contraindicated. Why? Because of the problem is seen in the dental composite. If the patient has some parafunctional habit, or some patients have this habit of putting the pen in their mouth while talking or whatever, so that's going to add more problems. Already your dental composite restoration, it has the problem of occlusal wear, and if you will add these parafunctional habits, if they are also present, well, it's going to increase the chances. It's going to happen much more quickly. Now coming to the finishing of dental composite, the factors which are affecting the finishing and polishing, well, it is mentioned in the Phillips Science of Dental Materials. There are three different factors. Environment. Well, if we talk about the environment, there are two school of thoughts. One says that you can easily finish polish the dental composite in a wet environment. Well, oral cavity is always wet, with the moist with the saliva. So it is said that okay, you can do the polishing procedure in the wet environment, but some people say that you need to use this rubber dam to isolate the tooth and then do the polishing. Then delayed versus the immediate finish. Well, in some cases, we ask patient to we do all the restoration, and then we leave the patient. We ask the patient and give him a second appointment to come after, let's suppose, 24 hours and get the finishing done. Right? There are some clinicians which advocate that it is better that we do the finishing in the same appointment. We do not go and come after 24 hours the next day and do the finishing procedure then. We just do it there and then we allow the patient to leave. But there are some clinicians there who ask the patient to come after 24 hours so that the material, the composite, it has polymerized completely, and then after 24 hours they'll do the finishing procedure. So it only depends on your experience and your expertise, what you have gained through your clinical skills, that what finishing that you prefer. Then the third type is the types of the finishing, types of the materials which are used for the polishing. Well, tungsten carbide burrs or fine diamond tips, they can be used to adjust the occlusal surface. Well, when let's suppose you're doing a filling in the upper region, in the molar region, and then there are, you check the high spots by the articulating paper and you see the high spots. Well, then you use the tungsten carbide burr or fine diamond tips. Well, they can be used for the occlusal surface adjustment. Well, then the oxide discs, well, they are present for a good to produce good surface and minimal trauma. Well, if these are present there, these are present in the finishing the composite finishing kit is there, and they have this aluminum oxide discs, and then you just put it on the handpiece and you can easily finish the dental composite restoration. Well, resin finishing devices, they can also be used. Fine or extra fine polishing paste. Well, these pastes are actually these pastes are most commonly used. Once you do the finishing, you just paint these uh, uh, these fine polishing paste onto your restoration, and then you use the buffing burr uh, to polish it, because in the end we need a polished surface. Our restoration should be polished, it should not have any rough surface, because I mentioned you the rough surface was a very big problem in case of the traditional composite. That's why the finishing and polishing is very much important. Then silicon based systems and silicon carbide, the polishing brushes, well, they are also available in the market. They are slightly expensive but they provide best results. So that was the lecture on dental composite. I hope it was very helpful for you guys. I tried to explain each and every part related to dental composite in an easy language. Though, well, it is a bit difficult to just summarize all dental composite, but I'm sure that it will be very helpful for you guys. So do see this video, and if there are any questions you can easily write in the comment section below. I will be there to answer all your queries. Do like the Dentoscope official Facebook page and the official YouTube channel Dentoscope Studio, and follow us on Instagram. Thank you so much for watching, and inshallah I will come to you next Sunday with a new topic. Thank you so much everyone. Take care. Allah Hafiz.